Good morning. The title of my paper is Heparinised irrigation fluid versus heparinised posterior chamber intraocular lens on postoperative inflammation after cataract surgery. Diabetic patients with cataract develop more severe postoperative inflammation as diabetic retinopathy causes a more severe blood aqueous barrier breakdown. The breakdown after cataract surgery is a result of trauma and of immunological reaction that causes protein leakage into the aqueous humor. The type of surgery and the implanted IOL influence the degree of breakdown and the postoperative inflammation. Heparin has well-established anticoagulant and anti-inflammatory and antiproliferative effects. Heparin surface modification leads to prevention of bacteria, protein, and lens epithelial cells attachment to the IOL surface. It also restricts the growth of fibroblast, macrophage, and induces less granulocyte activation and platelet adhesion. Studies have concluded that adding heparin sodium to the infusion solution during small incision cataract surgery induces inflammation in the early postoperative period. As PMMA IOLs were replaced by newer foldable materials such as silicone and acrylates, the use of heparin coating has reduced. Small incision cataract surgery and foldable IOLs have significantly reduced surgical trauma, resulting in less postoperative inflammation. But the inflammatory reaction is still an issue in patients with uveitis, diabetes, and pseudoexfoliation syndrome. The aim of this study was to evaluate the anti-inflammatory effect of heparin added to the irrigation fluid and compare it to the results of heparin surface modified foldable hydrophobic acrylic PCIOL after cataract surgery in diabetic patients. The comparative prospective study was conducted in the ophthalmology department of a tertiary care hospital. A total of 50 patients were divided into two groups randomly. Group 1 consisted of patients who underwent phaco with the addition of 10 international units per ml of heparin injected into the balanced salt solution, and Group 2 included patients who underwent phaco with the surface modified PCIOL implantation. Our inclusion criteria was patients with visually significant cataract with type 2 diabetes mellitus with or without diabetic retinopathic changes. Our exclusion criteria included pediatric, congenital, traumatic, and complicated cataract, patients with history of ocular trauma, patients having bleeding tendencies, and patients on systemic therapy with anti-inflammatory agents. All patients fulfilling our criteria underwent a detailed ophthalmic examination. The surgical technique of phacoemulsification was standardized for all surgeries. Post-operative evaluation of anterior chamber cells and flare were graded according to Sun classification, and iris pigments and cells on the intraocular lens was examined semi-quantitatively using a beam 3 into 2 mm and focused on 5 regions on the intraocular lens surface, and the average calculated. The results were compared between the two groups on postoperative day 1, 1 week, and 4 weeks postoperatively. Coming to the results, the baseline characteristic of Group 1 and Group 2 showed no significant difference in terms of age, gender, and duration of diabetes between the two groups. Coming to AC cells, there was a statistically significant reduction in AC cells postoperatively on day 1 and day 7 in Group 2, which is a HSM PCIOL group. And following a similar trend, AC flare also showed a statistical significant reduction in Group 2 on day 1 and day 7. Iris pigments also showed a reduction in postoperative pigment dispersion, which was statistically significant on postoperative day 1 in Group 2, and day 7 and day 28 showed no difference. The use of heparin in ophthalmic surgery was first described by Johnson and co-authors, who found that a single anterior chamber injection or heparin supplementation in the infusion solution or a single intravenous injection resulted in statistically significant reduction in postoperative intraocular fibrin formation. Larison et al. Demonstrated in vitro the improved biocompatibility of heparin surface modified lens with respect to outgrowth of fibroblast, macrophage, and activation of granulocytes and adhesion of platelets. These results were subsequently verified in vivo in terms of less inflammatory cells on the lens surface and fewer incidences of synechiae in the rabbit eye. Several studies have shown heparin surface modified PMMA IOLs have caused less inflammation than unmodified PMMA lenses. Heparin sodium added to the standard irrigation solution reduces disturbances of the blood aqueous barrier in the early postoperative period. There seemed to be no long-term effect, especially on cellular reaction and on the hydrophilic IOL surface. As heparin is proved to reduce inflammation and complications in pediatric cataract, diabetes, uveitis, pigment dispersion, and pseudoexfoliation glaucoma, adding heparin in the irrigation fluid or using a heparin surface modified PCIOL in these cases that are predisposed to enhance postoperative inflammatory response is a simple, effective, and safe modification that can be used in routine cataract surgeries. Coming to the conclusion, our study has found that heparinized irrigation fluid used along with acrylic hydrophobic PCIOL is not as effective as heparin surface modified acrylic hydrophobic PCIOL in reducing early postoperative inflammation. However, by day 28, the results were the same in both groups. The long-term effects of decrease in pigment deposits on the intraocular lens surface has also been demonstrated. Thank you.